afternoon, good evening. Our panel this morning is Be Prepared with Local Partners. I am Laura Martindale, a Senior Technical Advisor with the Biomedical Prevention Team in Washington, and I'm here today with our PrEP intern, Jennifer Duncan, who will co-moderate this session. We are very happy that all of you could join us today to hear from 3 local partners who have expanded PrEP reach in their respective areas of South America, Botswana, and Zambia. Next slide. As the evidence has shown, with more PrEP, there's more impact and improved prevention of HIV. As we can see here in this graph, PrEP reach has had a huge expansion in the last year, and much of this is attributed to the enormous work done by our local partners. Some of the key areas of achievement have been shifts in policy. Some of the guidelines have expanded eligibility for pregnant and breastfeeding women, which we will be hearing about today from some experiences in Zambia. There's also been a lot of expansion with event-driven dosing of PrEP for men who have sex with men. Many countries and programs have also successfully adapted to COVID-19 challenges, which continue to impact our communities. And countless partners have engaged their communities with innovative programming and demand creation to scale up access to PrEP. We are so excited to hear about how this is happening on the ground today. And I will now turn it over to Jennifer, who will introduce our panelists for today. You're all welcome to introduce yourselves in the chat. We do have some translation, maybe a little bit delayed, but it's on the way. And after our presentations, we will do question and answer. So if you have any, please enter them in the chat. And we look forward to talking and learning more from all of you today. Thanks, over.
Thank you, Laura. Good morning, good afternoon, and good evening. As mentioned, my name is Jennifer Duncan, and I am the PrEP intern for the Biomedical Prevention Team at USAID. I'm honored to have the pleasure of introducing our panelists for today's session. Starting off our panel, I'm very excited to welcome Josequinones. Jose is a doctor and surgeon who is currently the Regional Strategic Alliance and Special Projects Manager for the Pan American Social Marketing Association, PASMO. For his career, Jose has had the pleasure to direct and implement new projects and initiatives related to Zika prevention, sexual and reproductive health, maternal and child services, and quality assurance. Please join me in welcoming Jose. Thank you, and over.
Jose, I think you might be on mute.
Can you hear me now, Laura?
Yes, thank you.
Hey, thanks so much. I had some trouble with this. But I was telling you that I'm really pleased to be here. Thanks so much for the invitation. It's really a privilege for me to be speaking on behalf of PASMO and sharing with you this wonderful news of a baby we have in Central America. Next slide, please. Well, we are going to see some of our background and how we are delivering services of PrEP in Central America, how we are implementing the service itself, and some outputs and outcomes, as well as some lessons we've learned during this recent time. Next slide. We are PASMO, but PASMO, for you to know, is the Pan American Social Marketing Organization. It's a local NGO with offices and branches in Guatemala, Honduras, Nicaragua, and Panama, and having processes for having another one in El Salvador. Currently, we are implementing the USAID's prevention services against HIV, and we are involved in other health areas as well with other donors. Next slide. Central America, for those who are not familiar with our region, is just in the middle of the Americas. It's a small area, but altogether are 7 countries with around 50 million population. What is interesting of Central America is that we have 4 of the most prevalent countries in HIV cases. So, and the ratio of HIV in the region is 2 to 1 men to women. So that is something very unique, or makes unique the way that HIV is in the region, because it is concentrated, for saying that way, in men mainly, and men who have sex with men, and transgender women, and that's why our strategies are focused to those populations. Next slide. PASMO has a story of having relationship between the private sector with the private sector. Now we have 93 different laboratories or points of service who are providing HIV testings mainly, and other STI services to the population we serve. Next slide, please. And here I'm gonna explain a little bit slow how we are implementing PrEP in the region. And this is the model. This is the model of the implementation we are following. And here you will see a kind of chain with different links, starting with the demand generation. PASMO is well known in the region for generating demand through social networks. So we use Facebook, WhatsApp, TikTok, and others for generating demand, for communicating good news to the people, and for sharing information. And that's the first point of contact of more than 90% of our users. And after that, a team of cyber educators, people like in a call center with the special skills, are in touch person to person through the social network with the people offering the services. Some of the promotion is being done on the field activities with some collaborators we have, but most of the communication is happening in the media, in the social media. It is important to notice or to mention that this is the first time we have PrEP in Central America in a bigger scale. So after having this communication, these cyber educators send a link for making risk evaluations digitally, because of the pandemic, because of the way, the time we have for doing these processes. It is really quick, and the response has been really good. So after screening the people, we make references with coupons. The clients go to the private sector with doctors who are trained on how to deliver PrEP services and to receive some other services like lab testings, HIV, creatinine, and others that are part of the protocol. During this moment, the patient can receive all the counseling and other information important to see if he is available or eligible to start with PrEP. And in the same clinic, they are receiving the first PrEP dose. And after that, we give follow-up to all of them for next visits and other deliveries of PrEP. We always have coordination with higher level of services in case we find a positive case, for example, and coordination with ministers of health in the programs of HIV for having all the protocols and guidelines in place. As I said, this is the first time that we are officially introducing PrEP in the region, so none of the countries have a protocol, and we are working closely to them for having this installed in each country. Next slide. This is part of what we have for the implementation. First of all, we have created a guideline who is adapted from the MOH, WHO, PAHO, and others. Other sources that have more experience, for example, South Africa, some other from Europe, and the New York guideline, for having a compilation of information and create a guideline that is more adapted to our region, in understanding a little bit more of our context and what is the need of having PrEP in Central America. This guideline has information about HIV, about the PrEP itself, about the clinical management, how to give follow-up, and the pharmacovigilance, which is really important for this kind of services. Next slide. In terms of contractual activities, we have mapped our clinics, we have pre-qualified the doctors and the providers. We have done some negotiations for having good prices and having a really good access for the services. We have selected finally the clinics where we are working right now, and we have elaborated some contracts with specific topics to accomplish. Next slide. For now, we have been starting PrEP in Guatemala with local and in-person services. We have trained the doctors, the nurses, the lab technicians, and all the staff for delivering this PrEP, for make these services friendly to our populations, to key populations, to having free of stigma and discrimination spaces is really important, especially in our region, where doctors and nurses are not really familiar to key populations. So this is part of the training, and of course, all the technical content. The service delivery model is being adapted to in-person clinics, but we are now starting with telemedicine, which is going to be useful for those populations that normally don't attend to clinics, either if it is from the public or the private sector, or because of the time or other situations, COVID-19 and etc., they have the difficulty to go to a clinic, to a physical setup. Quality assurance is super important for us. We always implement, and it's a mandatory system that we are implementing among all our services. We are interested in that our providers accomplish with all the standards we have for the delivery of the service, and of course the monitoring and the evaluation, which is really important in terms not only of for reporting, but for following up what are the activities that they are delivering. Next slide. This is part of the demand generation we create. First of all, we are raising awareness about about PrEP. It is important to let the people know that we already have PrEP in our services. Then we are creating demand through the social network and sending messages for adherence as well. Next slide. Now we have 30 different clinics with more than 50 doctors that are almost ready to start delivering PrEP in other countries, but in Guatemala we have 10 different clinics and service points delivering PrEP to all the people who is nearby. And that is one of the abilities or the capacities that this program has. First of all, we have identified a clinic or a chain of clinics that have these different setups in different places, which makes more available the services for our users. Next slide. And some outcomes. This is just 1 month of implementation outcomes that I'm presenting. During 10 days of advertising, almost 400, and here we have 331 people, but almost 400 at the end of the month when we were capable to make all these numbers. Almost 400 people were asking for PrEP. Some of them, most of them received the link for making the risk assessment. 194 people were screened, 126 people were referred to clinics, and by that moment, 75 people were using PrEP, actually, for the first time in Central America. Next slide. And finally, some of the very recent lessons learned we have are focused to the service providers. It is really challenging to change the mindset of doctors in our region because, you know, medicine here is responsive, is not preventive. And changing that way of attending people, giving preventive services is something really, is unique and is a really good challenge that we are facing right now. despite having highly qualified doctors, HIV is something very specific. So we need really to train them on HIV in general, and the populations we serve is a topic we always touch. Training doctors using digital tools is not 100% accurate. So face-to-face is always essential. After the first training we did using digital tools, we had the need of visiting them for giving some feedback and supportive supervision all the time for improving the whole service. And the incorporation of new providers is always a challenge in terms of adapting the process required to provide HIV prevention services in the region. That's all. Thanks so much.
Thank you, Jose, for kicking us off and for that lovely summary of the work you are doing around preventive services and PrEP in the region. We will be saving questions for our panelists until the end. However, please feel free to drop any questions you may have into the chat for Jose, and we will circle back around to them. With that, please join me in welcoming our next panelist, Dr. Botale Mosandame. Dr. Mosandame is a medical doctor who holds an MBBS degree from the University of West Indies in Trinidad and Tobago. She has over 5 years of experience working in public service for the Republic of Botswana and is currently pursuing her postgraduate diploma in sexual and reproductive health under the University of South Wales. Over to you.
Okay, good afternoon and good morning to everybody. Thank you for the warm welcome. My name is Dr. Botale Mosandame, as has already been stated, and today I will be talking about our PrEP implementation amongst girls and young women in Botswana. And this is a voluntary counseling testing integrated approach done by Telemedicine. Can move on to the next slide. So as a background, through research, we found that adolescent girls and young women in Botswana, aged between the ages of 15 and 19, are twice as likely to be infected with HIV compared to boys of the same age group. And it was found that the use of pre-exposure prophylaxis as a preventative measure to reduce these new infections amongst this AGYW, as we commonly call them, in Botswana. It was first implemented by a Voluntary Counseling and Testing Center, which is a non-profit organization. This PrEP implementation was supported by USAID, FHI 360, and the DREAMS Initiative. Thank you. Move on. Okay. So as a methodology, what Development did, it offered PrEP through an integrated VCT model. Initially, we implemented this project in 2 locations, that is Gaborone being the capital city and south of Gaborone being Kwening East. And then it was later expanded to the northeast region of Botswana being Francistown. So this voluntary counseling and testing integrated approach, it was more designed as a one-stop shop for SRH and HIV services. So what happened is that we have different entry points. These entry points are through HTS, that's HIV testing services, family planning, STI, gender GBV, and non-communicable diseases screening areas. And these were used as entry points in order to assess the girls for PrEP eligibility. So our staff members were also trained on being able to implement PrEP to the specific target group. Then we also partnered up with our community partners, and these guys brought in pre-screened AGYW to our facility that is developed for PrEP initiation. Thank you. In order to create demand, we engaged with our marketing team, and through them, we were able to have engagements with local radio stations. And all of these efforts were done through the Ministry of Health and Wellness, and particularly these local radio stations. They have youth programs such as MTV Sugar, where they have more like film scenarios over the radio stations, and these film scenarios are more targeted towards adolescent girls and young women. And the medical doctor, for example, myself, are being invited to come and critique these scenarios and more answer some FAQs that were based on this film scenario. We also have our social media sites such as Facebook, Twitter, Instagram, and these were used to disseminate and sensitize these AGYWs on PrEP, especially since these are modes of communication that we realized that this target group really engages on, and especially during the COVID-19 lockdowns where there was restricted movement, there was an increase in social media usage. So what happens is that sometimes they have questions that they post on this Facebook pages and groups, and the questions that are related to PrEP would be answered by the healthcare workers. We also liaise with Dreams ambassadors. These are young women who are mentors to these girls, and we collaborated them a lot with popular AYGW sites such as beauty contests to come and create demand for these services. We of course also use print media as well as brochures on the clinic walls. In our center, we have what we call a Girls Hub corner, where our AGYW can be addressed separately. In these Girls Hub corners, we have magazines and some games where they sit down with more peer-related linkage to care officers, and they can guide them to initiate them on PrEP. And then finally, we also had community outreaches to universities within Gaborone. Gaborone is considered as the education center of the country. That means that the majority of universities are centered in Gaborone. So we took advantage of that and went into the colleges, paired up with the wellness teams within those universities, and we have satellite clinics where we go in every week, have a schedule, and we can initiate these girls on PrEP where they are living. Thank you. We can move on. So after we did all of this, our results came out, and here we've got the number of females who've ever been enrolled on PrEP according to the district. Like I said, we initiated them in Gaborone, Kweneng East, and Francistown. So initially, the uptake of PrEP was it was low, especially because this came around the time when we were being faced with the COVID-19 pandemic. But as you can see, within Gaborone, we steadily increased, where we had 306 clients, then we had 235 clients, especially that this time was when the country was on the lockdown. But since the restrictions to movement gradually decreased, we have had a spike in the clients who are interested in PrEP, and we initiated 1,144, and this number continues to increase every single day. The data that I have most recently, we are initiating up to 30 girls every week in Gaborone Center alone with PrEP. The same goes for Kweneng East, where we are now seeing a sharp increase in females being initiated on PrEP. And like I said, in Francistown, we extended the service this year, and so far we've got 409 clients who are on PrEP. So the APC project has enrolled 3,748 AGYWs in PrEP since the program started in 2018. We can move on. So through this research, we've realized some challenges, conclusions, and recommendations. So we have learned that the implementation of a VCT integrated model within the facility is not adequate. We require more community collaborations with NGOs and other institutions, because what we found is that our adolescent girls and young women, these are girls who are in university, they are highly mobile, and their time is very limited in terms of coming to the center and sitting down and waiting for the nurses to come and see them. So what we require more is that we need more community collaborations with other NGOs, other tertiary institutions, because yes, so moving on, we also realized that retention of AGYW on PrEP requires a lot of education because it continues to be a challenge, as the other presenters have already talked about. So we require a lot of community level education. We also require to teach the parents as well as the partners of this AGYW, because PrEP in Botswana, like we said, it's a very new development. It was amongst the first to introduce it, and a lot of people ask questions in relation to this this new model that we're having. So we really need to educate them more. We also need to really emphasize to the young girls on dual protection while on PrEP to avoid an increase in STIs. A stronger provider support system for AGYWs on PrEP, and relevant messaging on the side effects, as well as other issues and support groups should be emphasized within this program, because a lot of the young girls might not be aware of some of the minor side effects that can happen because of PrEP, and when they face those challenges, they tend to maybe leave the PrEP, saying that it's not taking them well. So we really need to emphasize more on educating them and treating the side effects as they come along. Next slide. So in conclusion, thank you very much for allowing me this time. I'd just like to send a special thank you to our executive director, our technical director, and monitoring and evaluation manager for assisting me in creating this, this presentation. Thank you.
Thank you, Dr. Musa Dame, for your engaging presentation on PrEP and AGYW in Botswana. Again, if you have any questions, please feel free to add them to the chat and we will address them at the end. Last but certainly not least, I would like to present our final panelist, Tikazi Jiri. Tikazi holds a BSc in Population Health Studies and an MSc in Public Health. She currently serves as the Regional Prevention Coordinator for Right to Care Zambia. In this role, she oversees prevention and clinical activities in 3 provinces. Tikazi has worked in the public health sector for over 27 years in service delivery and has conducted several clinical trials. Over to you.
Thank you so much. Yeah, so I'll be presenting on the equipped interventions into PrEP in pregnant and breastfeeding women. So this implementation is being conducted in northern Muchinga and Luapula provinces, which are in the remote part of Zambia. And this data is based on the October 2020 to March 2021 performance. And I aim to highlight on why we started giving PrEP to pregnant and breastfeeding women. Concentrating on this population was because of the high HIV incidence that was showing in the national data, and the seroconversion of the pregnant women during antenatal, and yet they could have tested negative in the first, during their antenatal booking. And then there was a high positivity of HIV-exposed infant, and hence the implementation of PrEP in pregnant and breastfeeding women. So the PrEP program is a combination of efforts, as women can be on PrEP, but they should also put in other measures, such as if they are breastfeeding, such as family planning, and for both categories, they should also use condoms as well. So the process of the PrEP program is that every HIV identified woman at antenatal booking is attached to a dedicated counselor that sees them through the program from pregnancy through to breastfeeding. Okay. So these women are attached to these counselors, and in the departments where they operate from is antenatal, postnatal, and under 5 clinics. The counselor does the process of counseling and testing, refers to, sorry for that, postnatal and under 5 clinics. The counselor does the process of counseling and testing and refers negative women to the clinician, or who is either a clinical officer or a nurse or a midwife. A clinician who further counsels and initiates the client onto PrEP. Those that are not ready, a directory is kept where they are followed up later. So the focus on pregnant and breastfeeding women, this initiative came from USAID when they also analyzed the country data, and then showed the concerns of data. And then the staff underwent a general PrEP training and other interventions to make it a success. We have been giving them remote guidance and on-site guidance to ensure that the process is continuing and being effective. So the methods that we have used, the training involved people from the laboratory, pharmacy, and MCH, labor ward, and the ART department, and the inpatient and OPD department. This was to ensure with the lab people, with the lab staff, we had to ensure that tests were being conducted for the clients, the creatinine and the LFTs. And then for the pharmacy staff, we wanted to ensure supplies were always in stock. For the MCH, labor ward, ART, and the OPD and IPD, we wanted to ensure that the staff knew what, because these were entry points for our clients, so that they should be on the lookout and always talk to our target population about PrEP. So HIV testing is mandatory in Zambia for all pregnant and breastfeeding women. And we have made this effective by conducting sensitization talks in MCH and antenatal, postnatal, within and outside the static facilities. And we have displayed job aids and charts. And we conduct a lot of community service in order to reach out, especially with the COVID. We concentrated a lot in decongesting the facilities, and we presented in the communities where we met the women. Women are followed up from pregnancy throughout until cessation of breastfeeding. And we also have done integration of services where we even dispense and initiate PrEP in the community. The inclusion criteria is that the woman just has to be pregnant and breastfeeding. And the exclusion criteria is for Truvada, where if they are weighing less than 35 kg. Next, please. So our demand creation, we our communities are communities that might not have other digital information equipment. So as a result, we have we work with the local radio stations and tailor the messages into the local language so that they can be understood. And we have what we call listening groups to ensure that people in the communities, in the villages are listening to the programs. And we have an ambassador, a media ambassador, who sees to it, who coordinates the listening groups. And these listening groups come in different categories. We have for the adults and we have for the adolescents. And health talks are given in the facilities and at community level. And we also collaborate with the village headmen. The village headman is so influential to their subjects such that they would give us a platform in order to showcase the services that we are giving. The service is being rolled out in all our facilities, especially newly adopted sites that we have brought on board. And we also conduct refresher training and orientation for new staff. And we are lucky that we are giving this service to pregnant and breastfeeding women because the facilities have a lot of programs that are looking at the care of women, health care of women. So this just shows the increase, the performance of PrEP that we've had on in the period. You can see that in October 2020, we only had a lower number of people, and we see the acceptance. We see April and May, a reduction in acceptance into PrEP. This was because that's when the country was hard hit by COVID. But in June, when the COVID numbers reduced, the numbers have again started to rise. So some of the challenges that we have faced as a country is that Zambia has got a high gender-based violence rate, and most of the affected are women and girls. And you find that our data shows that most girls from the age of 15 have already been abused, either sexually or physically or emotionally. And Zambia is also a patriarchal society, and most women are not assertive and can't make decisions on their own. And you see that our program is concentrated on women, and yet when you look at our data, you'd find more men accessing PrEP than the target that we are giving information to. And then we have poor retention, where partners might be able to stop because of if the male partner feels that they're not being respected, and why you don't trust me, why are you being on PrEP, and so forth. And lack of family support as well. Families, because of the patriarchal society, families usually present as the man as the head of the family, and the head of the family makes decisions. So that has also affected our service provision. The service remains poorly accessed, but we are trying our best to go out there and really reach out to the women and make it more accessible for them to receive prevention services. Next, please. So some of the achievements, even if we've had a gradual increase in uptake, but you'd see that even us just making it possible to enroll women, pregnant and breastfeeding women on PrEP was a challenge, but the numbers are increasing. And we believe with more sensitization, community education, we shall be able to reach out to more and have acceptability of women, pregnant and breastfeeding women being on PrEP. And the way forward is to strengthen the screening of pregnant and breastfeeding women and sharing their information. And yeah, so we believe with that, we'll be able to have a huge breakthrough. Because if we compare with the towns and where we are, the towns would have a bigger number because of the education levels and so forth. So I would acknowledge my gratitude to the people that have made this possible, Dr. Ben Chilwa, the country director, Dr. Philip Mwala, the deputy DCOP in the DSD, Dr. Ebedi Sadoki, Frank Chirokawa, our M&E advisor, Brian Muziamba, who is our guru in analyzing and collecting the PrEP data, and also Professor Lawrence Mananyanda and Dr. Costa Kinge and Professor Chasela. Thank you so much.
Thank you, Tikazi, and thank you to each of our panelists for sharing their experience and the well-rounded work that is being done on PrEP globally. I'm going to turn it over to my co-facilitator, Laura, for the Q&A session for our panelists. Laura.
Thank you again, Jose, Botali, and Tikazi for sharing your experiences. We do have a few questions that have come in, and I can see that there has already been some responses in the chat, so thank you so much. We have actually a hand raised by Rose Marie James. Would you like to ask a question to one of the participants? If you would like to, you can unmute and ask the question. Rose Marie James, would you like to share your question? Maybe not. Okay, moving on. We have a question for Botlali. Thank you for coming on. The question is, how has been the continuation on PrEP among 15 to 19-year-olds? Apart from the outreach at universities, do you also offer PrEP in the community? And during COVID, are you also doing community PrEP refills? Over to Botali to answer that.
Technology is a challenge here. I'm trying to reread the question. So just, I tried to give a chat response to say, I don't know how to go back on the question again. It seems to have disappeared on me. If you don't mind reading the question again for me.
No worries, Botali. The question was, how has been the continuation on PrEP amongst 15 to 19-year-olds? Apart from the outreach at universities, do you also offer PrEP in the community? And are you doing PrEP community refills during COVID-19?
Okay, so like I answered, so for our adolescent girls and young women, we categorize them according to the 15 to 19-year-old group, and then we've got the 19 to 24-year-old group. So for the 18 to 24-year-old group, we realized that these clients, retention on PrEP is a challenge. It is a serious challenge for them, especially, like I mentioned during our research, that a lot of the girls would come in and they're quite surprised by maybe some of the minor side effects that they would experience. And sometimes they would then end up leaving PrEP, or maybe some of the challenges could be including the fact that people associate any kind of HIV medication to being HIV positive. And so they face some stigma because these girls actually, like in the colleges, they share rooms with other girls. And they might be afraid that this girl might think that I'm HIV positive, so they end up leaving some of this drug. So it is a challenge, and we continue to try to educate and sensitize the community on this treatment, this prevention drug. So for our girls who are under the ages of 18, by the laws of Botswana, they cannot consent to going on treatment without their caregivers being aware. So we collaborate with the DREAMS program to assist us in meeting the parents, who then are given counseling as to what this is about, and to give consent for the girls to go on PrEP. I hope that answers the question.
Thank you, Botali. Did we ever find the hand that was raised? Was there someone that wanted to ask their question?
It was raised in error. So no problem.
No problem.
We can go ahead and move on to the next question. This next question is for Tikazi, and it is, how were disclosure issues handled between the pregnant clients and their partners? Tikazi, over to you.
Thank you. So the disclosure is done with, because now the program in Zambia encourages every pregnant woman to come with their partner to the facility for testing. But still, that does not mean they won't still get the service if they came alone. So there's couple counseling being done to both, to the couple, and then disclosure is given. And we are also doing PNS, sexual partner contacting. So even if you were to test positive away from, from the antenatal department, you will still need to follow your partner or partners in order to ensure that they also are tested and are either put on preventive measures or treatments.
Thank you, Tikazi. We had a question coming in for Jose. I do believe that this may have been answered in the chat, but the question was regarding PrEP medications and the data system between the private sector and MOH, and how are those connections being made with the data?
Thanks so much for this question. This is a very interesting one. First of all, medicines are being donated by PrEPared USAID for us and for all the programs that are working in Central America for now, while the governments have the capacity to buy by themselves first, and maybe some plans of social marketing in the future for those that can afford and buy for the medicines or pay for some services. That's part of the plan in both sides. So the government is not out of this plan, as I answered the first question in the chat. We are working with the private sector because other implementers are strengthening the government and the MOHs in the region. The second one is about the information we are generating. We are working with technical groups in the Ministers of Health for creating all the protocols, the guidelines, and it includes the way that they are going to get and report PrEP. So for now, we are holding the information, but at the moment that we can share it to the governments when they'll have the system. During the last 10 years, more or less, PASMO has been working in HIV testing. So we are very well connected with the governments reporting all HIV testings and positive cases and findings and so on. So we expect to have the same interaction with the government in terms of PrEP reports. Over. Thanks.
Thank you, Jose. Okay, the next question is about person-to-person follow-up and the challenges with COVID-19, and how have you been able to bridge that gap? In what innovative ways has individual follow-up been done? And is telemedicine working in this context? I think this is a question that we can have each of the panelists present. If we want to go, Jose, Botali, and then Tikazi can also respond to this question. Over.
Thanks so much. I will be first. Sorry, ladies. Yeah, telemedicine is such an important tool. We are working right now in implementing or transferring all the capacity we have installed in place to telemedicine, but not only for COVID-19. Some of the people we serve are, for example, transgender women that never go to physical services, for example. So they will be benefited with that. Others can be those that live far away but have internet connection. For example, in Guatemala, we are around 60 million people, and we have like 70 million cell phones. So connectivity in this country is really high. So this is another approach we can have. So telemedicine can solve a lot of problems, especially for those services that don't need in-depth evaluations, rather than just having a kind of very general medical evaluation with questions and checking some labs that can be done nearby. Thanks. Over.
Thank you. Botali, do you have anything to add about that?
Hello. Yes, with regards to telemedicine in Botswana in relation, especially in relation to Developele, this would be a very welcome movement that we would have. But in Botswana, we have a challenge in that, especially in terms of our AGYW, I think there's a great shift more from telemedicine to more digital platforms, if I were to say that, because of the AGYWs that we present. They're more into the traditional forms of the telephone. We're moving away from that, and we've got more social media platforms. For example, at the clinic, we use forums such as WhatsApp, where the girls can interact on WhatsApp and talk to us. And like I said to you, we also have our Facebook pages and digital media pages that are done by our marketing team in conjunction with our healthcare workers. So maybe for me, from our side, we're moving towards that, because we are more focused on that generation, and that generation is more into digital platforms. We have to move perhaps with their way of doing things. Maybe we might not understand because we might be older, but that's where I would be more inclined to go. For the older generation who are more in the rural areas, yes, telemedicine would be a welcome initiative, because they still use traditional forms of media.
Thank you very much. Tikazi, over to you.
Yeah, thank you. So with, I think I started with saying the geographical area of where we are operating, and it's in the remote areas. So I think digital utilization is a bit of a challenge, though we have a call center that reminds clients of visits and medication pickup. But we have gone into an innovation of building community pickup points. We ask the community where they are comfortable to collect them. It might be a church building, it might be a school, it might be a shop. So we pack their drugs and they collect them from there. And we also have counselors that do door-to-door drop-off in their homes, and that is working well for us. Because I think we remove the transport aspect and the distance, and we have the resources to reach out to them. So door-to-door and community pickup points are working very well for us.
Thank you so much, Chikazi, and thank you to all of our panelists. We have really appreciated hearing your experiences. We are grateful for all of the work that you are doing as local partners, increasing access to PrEP. Keep up the great work. We will have Jennifer wrap up a few key takeaways for us, as we only have a couple of more minutes left in the panel, but we do look forward to continuing this conversation with all of you moving forward as we increase more and more access to PrEP. Thank you.
Thank you.
Thank you, Laura, and thank you to each of our panelists. As Laura mentioned, I'm just going to wrap up with a few key takeaways. Each panelist brought something unique to when we look at PrEP, and some of the things that I really took away were the importance of social media channels and telemedicine as a tool, PrEP uptake and continuation among AGYW, and how that requires close community collaboration and education at the community level among family members and partners, as well as the importance of demand creation, especially for pregnant and breastfeeding women, including sensitization talks, and making sure that services rolled out at all facilities, as well as door-to-door and community pickup points. These are things that seem to be working, and are things that I think can be adapted for local partners in other countries as well. We really appreciate each of our panelists and all of the attendees that took time today to listen. If you have any other questions, please feel free to reach out. Our panelists' emails are also included, and I'm sure they would love questions for you as well. Thank you again, and have a good morning, good afternoon, and good evening, everyone.
Thanks a lot.
Keep safe, everyone.
Thank you so much, Lindsay.
Thank you so much.
Thanks.
Bye to Cassie. Bye, Batale. Thanks, Jennifer and Laura.
Bye.
Yes, thank you.
Hi, guys.
It was nice meeting all of you.
Very nice to be with all of you.
It was lovely to
today.
meet everyone. I think we had a great panel, so thank you for coming out.
Yeah, thank you so much for
Thank you so much.